Okay, folks, thank you for joining today's webinar. One thing I wanted to mention very quickly for those folks who are going to be applying for continuing education credits, social workers or licensed mental health counselors, this is some of the information that you'll need to get those CE credits or that CE credit. You'll see there, just go to that URL, https //SSW forms ESIT. So go to that link, and you'll have the instructions for registering for today's webinar, but also the instructions for getting the CE credits. Then just see, and if you have any questions for getting them, so the instructions are there. This webinar will be posted on our website within 48 hours, so if you need to revisit these instructions, they're there. But if you have any questions, you can call the School of Social Work. It's actually the School of Social Work here at NYU that's providing the CEs for this. You can contact them at that number and at that email address. We're going to review this information again at the end briefly for anyone who needs it. So with that said, let's get started. The other thing is, before we begin, I want to mention that just a couple of logistical issues, technical issues. If you come across any problems during the course of the webinar, please feel free to chat to the host. You can find the chat box on the right side of your screen, and if it doesn't appear there, click the dialog bubble on the top right toolbar, and it'll pop up. And again, if you have any problems, chat to the host, and she'll try to address it. During the webinar, you can chat comments or questions to the panelists, and then we'll compile those as we go along and bring them up at the end for our presenter today to address at the end with other questions during Q&A. So thanks for joining us, and let's get started. So on behalf of the Community Technical Assistance Center of New York, it's my pleasure to welcome you to today's webinar. And today's webinar is entitled Providing Services to Students with Clinically Significant Difficulties Following Trauma Exposure. My name is Jim Rodriguez, and I'll be the moderator for the webinar. By way of reminder, this is the 5th installment in our series on trauma-sensitive schools. And in that series, we've proposed a 3-tiered model for trauma-sensitive schools. For recordings and slides of the previous 4 webinars, please visit the CTAC website and you'll see what we've done in the past. Today's webinar focuses on Tier 3 or targeted interventions and for children and youth who are experiencing problems related to exposure to trauma. So at the end of today's webinar, please complete our brief survey to give us some ideas for additional topics you would like covered in this series. Today, we're fortunate to have Dr. Sarah Kate Bierman. Dr. Bierman is an assistant professor in the Department of Educational Psychology at the University of Texas in Austin. She received her PhD in clinical psychology from UT Austin in 2005 and completed her pre-doctoral internship at Columbia Presbyterian Children's Hospital of New York, where I also worked for a little bit, and a postdoctoral fellowship at Harvard Medical School. And Dr. Bierman's research is exciting. She focuses on the dissemination and implementation of empirically supported practices, ESPs. So that's evidence-based practices, research practices, or practices that have some good research behind them for youth. And she is particularly interested in research practice partnerships to increase fit, adoption, and sustainability. She wants to get the best research that we can out there in the community and in places where it can serve people best and in real-world settings, including in schools. So she does research on treatment redesign. She looks at elements or components of evidence-based treatments or practices that are out there, and she works on supervision and supervision approaches to help people implement those practices. And she also looks at using non-traditional providers to implement evidence-based or evidence-supported practices. And her work is supported by the National Institute of Health, the MacArthur Foundation, the Annie E. Casey Foundation, Foundation and others. And she's co-authored a transdiagnostic intervention manual for youth conduct, anxiety, depression, and trauma disorders. One of the things that Dr. Bierman is really good at is looking at matching need to assessment. So identifying kids' needs and matching the right intervention to the needs of the child. And she's going to talk a little bit more about that today. So with all that said, I want to turn it over to Dr. Bierman.
Thank you so much. What a nice introduction. It's so nice to talk to everybody today. So as was mentioned, the focus today is providing services to students with clinically significant difficulties following trauma exposure. And this is just a small piece of what's involved in ensuring that a school is trauma sensitive. So I hope you'll look at the earlier webinars. If you didn't already see them, I looked at them and was really impressed. So, okay. Who am I? You just heard all about me. I don't want to bore you anymore with that, but just to let you know, I'm a child clinical psychologist. I do have a research lab here in Texas, but I was trained in New York, so I have a lot of sympathy for the weather that you guys are experiencing today because I've been through it in New York and Boston myself. I won't tell you about how all the flowers are just starting to burst into bloom here in Texas. And you are welcome to check out my lab website, which I've posted for you, and hear about some of the projects that we're doing that focus on moving scientifically supported treatments out into community settings where they are most needed. So today, my plan for us is to quickly focus on the impact of traumatic events on kids, as well as the way in which supports are provided within schools in terms of the multi-tiered systems of support. I think probably this is familiar stuff to you, and especially if you had the chance to attend the prior webinar, so I won't spend too much time on that. And then move into talking about what kinds of services are appropriate at that third tier or targeted tier, thinking first about the clinical presentation of kids in that highest need bracket. How do children who've been exposed to traumatic events who are have impairment, how do they present? And then talking about some of the well-established treatments to address their symptoms. And then talking about how to approach using treatments flexibly in order to best match treatment strategies, or what I'll be calling practice elements, to the presentation of an individual client. And then lastly, we're going to hone in on one particular practice element, which is prolonged exposure via trauma narration, and then we'll definitely have time for questions at the end. So please, as you're listening and questions are coming to mind, I hope you'll make sure to ask them. Okay, so starting with the impact of traumatic events on children, just want to make sure that we're all on the same page with regard to our definitions, because many children experience stressors. For example, things like parental divorce, moving and changing schools, even in bullying more and more. And for the most part, these are more common and less extreme than traumatic events, although certainly bullying can escalate to the level of a traumatic event. But a traumatic event is defined typically as exposure to an actual or threatened harm or fear of death or injury. And these tend to be more uncommon, more extreme events. They certainly can be one-time events, although quite often they are recurrent, chronic, complex traumatic events. We know that exposure to one traumatic event actually increases the likelihood of more traumatic events for children. So included in this broad category would be things like physical or sexual abuse, neglect, exposure to violence, medical traumas, accidents, natural disasters, war, refugee trauma, or traumatic loss. And this might also be really familiar to you guys. Much of what we know about the long-term effects of trauma exposures comes from the ACE study that you may have heard of, the largest or one of the largest studies looking into the impact of child abuse and neglect and later life health and well-being. was originally done in the late 90s with over 17,000 participants who reported on their childhood experiences as well as their current health status. And in a nutshell, what we learned from that was that a number of different adverse childhood events had an impact on later health and wellness outcomes, including obesity, drug use, chronic disease, early death. And we think that this was transmitted through experiences that people have, then impacting their neurodevelopment, and then in turn that impacts how they interact with their environment. One of the most important things that we learned from these studies is that as the number of adverse childhood events people experience increases, so do the risk of poor outcomes. And the majority of people in the study, as you'll see on the next slide, experienced one or more ACEs in their life. So this is both the original study and the 2010 replication study that shows that more than half of all people had experienced one or more ACEs, and that is related to all kinds of negative health outcomes. The way I think about it is these adverse childhood events literally get underneath your skin, and they affect all kinds of outcomes for children. So in thinking about child maltreatment, we're talking there about physical abuse, neglect, sexual abuse, and emotional abuse, and I think probably all clinicians are well aware that this is a tremendous problem in the United States. A report of child abuse is made every 10 seconds. We know that 1 out of 10 children also receive harsh physical punishment by a parent or other caregiver, which puts them at risk of injury. So really, when we're talking about kids who've been trauma exposed, we may be talking about quite a number of children that you treat in schools or in clinics. And this is just a quick breakdown of the types of maltreatment by percentage, looking at physical abuse, neglect, medical neglect, psychological maltreatment, and sexual abuse, as well as other. And lastly, on this topic, here's the ACE pyramid. You can just see the conceptual framework that I already mentioned, wherein adverse childhood exposure, or ACEs, lead to negative outcomes, including early death. And it's been theorized that the process by which this occurs is disrupting neurodevelopmental processes, which puts children at risk, and then leading to social, emotional, and cognitive impairment that, as they interact with their environment, also can increase the likelihood of health risk behaviors that lead to disease, disability, and social problems. So all this to say that stress is not great for children. I'm sure you guys all know that. But it does affect kids in different and unique ways. So over time, what we find is that repeated traumatic stressors or chronic stress can result in neurological and chemical changes that can lead kids to have very hyper-responsive reactions, so they can have hypervigilant systems, or hypo-responsive reactions, where we see more of a blunting or numbing effect. And overall, chronic stress sort of takes a cumulative toll on biological systems, which is known as the allostatic load. So the way I think about this is that we know that all of us have built-in body alarm systems that are there to help us stay safe, right? This is how normal anxiety works. Our bodies are hardwired to react to threat. So in the face of a threatening situation, a stimulus, we make an accurate interpretation of threat. We think, oh, there's so much snow outside that if I were to go outside, it'd be really dangerous. And maybe we feel anxious when we think about driving in it. And that anxious arousal is there to keep us safe. It allows us to either fight, flee, or freeze. So essentially, our sympathetic nervous system kind of clicks into gear and is working to keep us safe. And this is really good for situations where you're walking through the woods in New York and you come upon this fellow, right? You would want that fight, flight, or freeze response to kick in. Anxiety becomes disordered when we make a misinterpretation of threat, but still have that same fight, flight, or freeze reaction, right? So when we're in this, the presence of a safe stimulus, something that can't really harm us, but we make an interpretation that we're in danger, our body can't really tell the difference. And so we go right into that sympathetic nervous system response, that fight, flight, freeze response. And this is not great when we're confronted with things that aren't actually dangerous. For example, a teddy bear or the Care Bears, or actually this mascot might be dangerous. I'm not sure. It looks a little threatening. But that's how anxiety works. And over time, that fight, flight, freeze response actually has an impact on our physiology. It has immediate impacts. You can see it, right? People's pupils dilate. You might feel your heart rate increase, your breathing increases, you might start to sweat. And again, if you have to run for your life, these are good things. That's going to prepare you to do that. There are also hidden effects. So your brain prepares your body for action. It releases adrenaline. You're going to release cortisol, which actually depresses your immune system. Again, necessary in the face of an acute stressor that's dangerous to you. But over time, if you keep misinterpreting threat, or if you're experiencing chronic threat over and over again, this takes its toll on your body. And one of the ways that we see that trauma exposure really impacts kids can be seen in this graph right here, where it looked at the effect of children in school who've been affected by trauma. So we know that 1 in 4 children in school have been exposed to a traumatic event, and as I've already mentioned, that this chronic exposure can affect the chemical and physical structures of the brain, and that can lead to difficulties with concentration, memory, focus, problem solving, emotion regulation, etc. Here you see the rate of which, the proportion of children who are flourishing in schools, and flourishing here is defined as being engaged and motivated, being able to regulate emotions, and being able to attend. And what you can see in a nutshell is that when you don't have any ACEs, we have the highest level of flourishing, and that with each additional adverse childhood event, the rate of flourishing decreases. So clearly this is affecting children in the school context. Okay, really quickly, how do we address these kids in the context of schools? We have in schools a multi-tiered system of support with the idea that at Tier 1, we have universal best practices. This is things like your social emotional learning curriculums. It should be for all students, and with the understanding that we don't know what kids have been exposed to trauma, and so we should have best practices at the universal level that are sensitive to those children who have experienced trauma. At the next tier, we have students who may be at risk because of their membership in particular groups that are more likely to experience trauma, or because we know that they're showing some academic difficulties, or maybe they have some symptoms of clinically impairing problems, but they don't meet criteria for a disorder. And for those children, we typically recommend evaluation, additional classroom supports, and maybe small group programming or accommodations. And then the final group, which is where we're going to be talking about kids today, is that third tier where kids are already experiencing clinically elevated levels of impairment. These are children who might meet diagnostic criteria for a mental health disorder as a result of their trauma exposure. And there, what we recommend is evidence-based assessment and intervention provided by a mental health clinician, typically. At the other two tiers, we might be providing services by teachers or other non-mental health professionals, but at the third tier, we really recommend that they be mental health professionals. Okay, so what are those services like? Well, I want to talk a little bit first, actually, about the clinical presentation of children in the third tier. So when I say that they are being affected by maltreatment and trauma, most people immediately think about post-traumatic stress disorder. And I'm going to review symptoms of PTSD in just 1 second. But the truth is that that might be a relatively small subset of kids. You know, children are incredibly resilient. One large epidemiological study of children under the age of 16 found that although 68% of children had been exposed to a traumatic event, less than 1% of them actually went on to develop PTSD. About 2% had multiple PTSD symptoms but didn't meet full criteria. And many of them had other mental health needs, but did not meet criteria for PTSD. And that's important because different diagnostic categories require different types of services. So actually, depression can be a very common outcome of trauma exposure in children, and conduct or externalizing problems, or what I would call disruptive behavior disorders, are actually one of the most common outcomes of trauma exposure for children. So we know that kids, for example, in the juvenile justice population have very high rates of early childhood maltreatment or exposure to community violence. And in fact, the way in which that exposure may manifest is more with rule breaking and disruptive behavior problems. Conduct and externalizing problems are the most common reason for referral, particularly in, for example, foster care populations where we know there's high rates of trauma exposure. The other thing that I want to call your attention to is that conduct and externalizing problems are both predicted by trauma exposure and they predict future trauma exposure. So it's really important to address conduct and disruptive behavior problems when they're occurring, because having those kinds of behaviors actually increases the likelihood that a child will be exposed to trauma. So the bottom line is the majority of children exposed to trauma don't actually develop post-traumatic stress disorder, and therefore they may need treatment that focuses on other things besides the symptoms of post-traumatic stress, which we're going to talk about next. So when we talk about trauma and stressor-related disorders, I'm mostly focusing on post-traumatic stress disorder and acute stress disorder. And post-traumatic stress disorder involves the development of symptoms following exposure to one or more traumatic events, and the traumatic events are defined here as including directly witnessing or experiencing in person or learning about a trauma or having repeated extreme exposure to aversive details of trauma. And there are some key symptoms I'll review more on the next slide, but really a hallmark symptom of PTSD involves re-experiencing, either via flashbacks or intrusive memories. So once you've had this experience, you sort of can't get it out of your mind. It keeps coming back over and over again, even when you're trying to do other things. It's also characterized by anhedonic or dysphoric mood states, as well as negative and disruptive cognitions, physiological arousal and reactive externalizing behaviors, and sometimes dissociative symptoms. So here are the DSM-5 criteria for PTSD. And I just think it's really important that you notice that you need each of these categories has to be met. So just because someone has experienced a trauma doesn't mean that they will show these particular symptoms. And treatment for PTSD really tries to resolve these particular symptoms, and so it's not appropriate for people who don't experience these symptoms. There's also a preschool subtype that looks a little bit different in PTSD. We need fewer symptoms, and it can also very often be that the intrusive symptoms show up as repetitive play or reenactment. And then acute stress disorder is similar to PTSD, but it can be diagnosed sooner because it occurs within 1 month after exposure versus within 6 months. some kids who react to more common and less severe forms of stress in an unusual or disproportionate manner may qualify for a diagnosis of adjustment disorder. So I want to talk briefly about the theoretical model of PTSD that was put forth by Ehlers and Clark in 2000, because it's been suggested that our reaction to trauma becomes really problematic when the way that individuals process the trauma leads to a sense of serious, current, ongoing threat, even after the threat has actually ended. So part of what is theorized is that during the event, there's incomplete emotional processing. And you'll note here that there are a couple of predictors of that are in the model even before the traumatic event, and those have to do with previous life experiences that may make kids more vulnerable to experiencing PTSD, such as, for example, not having secure attachment or having an anxiety disorder. Those are things that increase the risk of PTSD. And some attitudes or beliefs about the world, even before the traumatic event. For example, thinking that the world is not safe. During the traumatic event, there's this incomplete emotional processing that results in the story of the event sort of being disjointed. In other words, it's not a linear story the way it's been stored in our brains. It's kind of out of sequence or uneven. I think about it like the way if you peek through your fingers at something scary, instead of really looking at it, you don't see the whole picture. That's a little bit like what the story of the event is like for kids with PTSD. And then following that, because of this incomplete emotional processing, they develop an attention bias for threat messages at the cost of attention towards more neutral messages. So in other words, these kids then start scanning their world for messages that tell them that there's threats present, and they are not able to devote as much attention to messages that tell them that threat is not present. And there's also a shift in awareness of their own traumatic cognitions at the expense of neutral cognition. So in other words, they are beginning to have more negative automatic thoughts about themselves, about the world, and these cognitions are given sort of priority over more neutral cognitions. And the way in which that can present kind of in your office or in the moment is kids who are, need to advance the slide. Kids who are experiencing intrusive memories or appraisals of the trauma. So they're having these intrusive thoughts about the traumatic event and what happened afterwards. They also may feel in the moment that they are currently in danger. They have a sense that it's happening all over again, even when they're not in danger. So they have these appraisals of risk. And they also have these negative appraisals of their self and their ability to cope. So in addition to having memories of the abuse, they also feel that they are currently in danger and they believe that they are not capable of handling what's happening. And we then see that they have these physical symptoms and emotional responses, so they're physiologically aroused. They are constantly in a state of being ready to fight, flee, or freeze. And that sort of partnered with these behavioral and cognitive responses that include avoidance, so perhaps avoiding things that remind them of the trauma or trying to avoid their own thoughts. Sometimes emotional blunting or numbing, trying to sort of shut down their emotional reactions, as well as negative thoughts and hypervigilance, checking, being prepared to flee in the case of danger or to fight. There are some risk factors that increase the likelihood that a traumatic event will lead to post-traumatic stress disorder, as I mentioned before. Actually, being a girl is one risk factor. Being the member of an ethnic minority is another. And then there are some characteristics related to the trauma. So we know that traumas that involve interpersonal violence, such as sexual assault or domestic violence, are more likely to result in post-traumatic stress disorder than, for example, impersonal traumas, such as things like being in a natural disaster. Having a pre-existing anxiety disorder or distress disorder like major depression increases the likelihood that you'll develop PTSD. And then, as I already have said, behavioral disorders increase the risk for exposure to traumas. So having oppositional defiant disorder or conduct disorder increases the likelihood that you'll be trauma exposed. And then lastly, having another trauma exposure increases the likelihood that you'll have a future trauma exposure. So we know that it's not uncommon for children to have multiple exposures. So I've talked about PTSD now, but now I want to shift and talk about another clinical presentation that you are likely to see for children who have been trauma exposed at that third tier, and that are conduct problems or disruptive behavior disorders. And this includes oppositional defiant disorder, a recurrent pattern of negativistic, defiant, disobedient, or hostile behaviors, and conduct disorder, which has to do with more the persistent violation of rights of others and societal norms. We know that this comprises about 5 to 10% of youth, but in clinical populations, this is actually often more like 40 to 60% of a clinical caseload. So this is the most common reason for referral. And we know that if left untreated, these problems don't get better. They have very negative trajectories. And it's, as I mentioned, the #1 reason for referral within U.S. mental health services, and also the most costly for society. So it's very important to intervene, and although, again, when we think about traumatic events, we often think about PTSD, it's actually more likely that a child who's experienced a traumatic event will present with acting out behaviors or externalizing disruptive disorder behaviors. And that's why assessment is so important, because kids who've effectively processed the traumatic event, that is, they're not sort of hung up in their processing, they're not re-experiencing. They don't need treatment that focuses on the trauma per se. They might need other interventions to manage their mood, to manage anger, to improve their behavior, but they wouldn't need a trauma-focused intervention. And that is important because when kids have effectively processed a trauma-focused intervention can actually be problematic. It may actually make them worse. So it's really important to do your detailed assessment. I recommend a couple of different well-validated evidence-based scales. And then I also think it's important to do broad measurement. So maybe a structured diagnostic interview or some kind of a measure like the Achenbach forms, the Child Behavior Checklist and Youth Self-Report, or the BASC, that assesses broadband concerns. Because we don't want to assume that just because somebody has experienced a trauma that what they need is a trauma-focused intervention. Okay, so moving on to talk about what services we do think are best for these kids. I want to start by talking about how we can think about practices rather than whole treatments. So everybody knows there are a lot of treatment manuals out there right now, or whole treatment approaches. But more recently, Bruce Trapita and his colleagues have been kind of taking these treatment protocols, say, for example, trauma-focused CBT manual or coping with depression course for adolescents. These are whole treatment manuals, and kind of pulling them apart to look at what are the common elements that appear across diagnostic categories. So this is a little bit like if you have one recipe for chocolate chip cookies and another recipe for a blondie cookie. They have some same ingredients and they have some distinct ingredients, but to make either you need certain things, and this is also true for treatment manuals. So what do we know from the evidence base about treating post-traumatic stress disorder? Well, we know that CBT with parent involvement receives the highest level of support. There have been 4 randomized clinical trials to show that it is the #1 treatment that is better than comparison conditions, and there's good support for CBT without parent involvement for 5 randomized clinical trials. I just want to note that there's minimal support for some of the interventions that I certainly hear about people using, such as play therapy and psychodrama. And then what does the evidence base tell us about treating child disruptive behavior? Well, we have 41 randomized clinical trials showing that some version of parent management training or behavioral parent training is effective. We have 9 randomized clinical trials that recommend multi-systemic therapy, which also really involves focusing on parents, and then some other treatments. But I think it's pretty convincing to say there are 41 randomized clinical trials showing that working with parents to address their children's needs in a parent management training protocol is more effective than other comparison conditions. That's a huge evidence base. So we have these 2, different interventions that have been shown to be really effective, one for conduct, one for trauma. I'll just take, for example, Defiant Children, and for example, trauma-focused CBT. But really, what I want you to understand is that behavioral parent training broadly, any treatment where you're working with the parent to help their child and you're focusing on behavioral interventions, those are effective, and any trauma-focused intervention where you are using CBT to address the traumatic event, that's also effective. So these are 2 different manuals. How do we unpack them to find the specific components that are effective? So we can derive the common elements by looking at a family of treatment and then looking at the protocols within. So for example, for behavioral parent training for conduct problems, we have parent management training, the Oregon model, we have parent-child interaction therapy, we have Defiant Children, there are other brands. Those are all different brands of this broad family of treatment. And then if we open up those manuals and start looking inside, we find individual practice elements, things like paying attention to your child's good behavior, actively ignoring the behavior you don't like, using some kind of discipline procedure like timeout. And then there might be some differences among them. For example, reprimands is part of parent management training, but it's not part of PCIT. These are all practice elements. And you can actually look across different disorders. For example, Defiant Children for conduct, Coping Cat for anxiety, Coping with Depression course for depression, and find some similar practice elements there, right? Like they all involve problem solving. So what are the practice elements used in post-traumatic stress disorder? Well, the most common element that's used in all effective treatments of PTSD, that is, treatments that have shown to be more effective than a comparison condition, is prolonged exposure. 91% use that, as well as cognitive restructuring. And then you can see that psychoeducation, relaxation, and caregiver psychoeducation are also common. And then there are some lower frequency elements that might be less important. They show up less frequently in these successful interventions. We can do the same thing when we look at the practice elements used in the treatment of disruptive behavior disorder. So the most used elements are things like teaching parents and teachers to give praise, teaching parents and teachers to use a safe discipline procedure like timeout, the use of tangible rewards to increase compliance, the use of effective commands. Lower frequency elements include things like insight building or anything really where you're working directly with the child. Those are not as common in effective treatments for conduct problems. So that really tells you that you need to be working with the parent or with the teacher to address those problems. So this is actually a flow chart from the Modular Approach to Treatment for Children, which is a way to flexibly use different practice elements to address kids with comorbidities or kind of complex presentation. And what I just wanted to quickly show this to you because what I've circled here is the sort of classic protocol for somebody who has post-traumatic stress disorder if they don't have other problems. So you do psychoeducation, you build a hierarchy of the things that they're afraid of, you do some psychoeducation, and then you move quickly into working on the trauma narrative, which I'll talk about in just a second. And then if the narrative is complete and they have made all the gains that they need, that's it. But if you have a kid who has more complex presentation or maybe has conduct problems, you might not work on the narrative. You might instead pull in some of these other strategies that are conduct related, like timeout, rewards, active ignoring, or maybe the child has more of a depressive presentation, so you're going to do some of the strategies that we tend to think of more often for treating depression, like cognitive restructuring or relaxation. Okay, in the time that we have left, I want to focus quickly on prolonged exposure via trauma narration as a key practice. This table comes from trauma-focused CBT, and it's all of the evidence-based intervention techniques that make the word practice. And so you can see that really at the start, even for this treatment, parenting strategies are a key piece. So this involves working with parents to help them work with their children. And then I've highlighted trauma narration as the key practice for trauma that we're going to focus on. Whenever I talk about doing prolonged exposure with trauma narration, I like to remember this quote by Maya Angelou, history, despite its wrenching pain, cannot be unlived, but if faced with courage, need not be lived again. And this really helps me to understand why it's so important that we ask children who've experienced traumatic events, who are having difficulty processing those events, to focus on those events again, despite the pain that is involved with doing so. So prolonged exposure for post-traumatic stress disorder is a key treatment strategy for effective treatment of PTSD. And with children, we often use the story of the trauma, or what's called a trauma narrative, as a way to approach exposure. So exposure in trauma is not re-exposing them to the actual trauma. We would never do that. However, for children who've experienced trauma, the memory of the traumatic event has not been effectively processed and is causing them distress. It's continually interrupting them when they want to be doing other things, thinking about other things, and they're feeling like the traumatic event is happening all over again. So we want to use prolonged exposure to the traumatic memories as a way to help them integrate the experience and learn that they can think about the memory and not be in any danger. So we want the memories, we want them to be in control of the memories rather than the memories being in control of them. And what we're really doing is, like exposure to anything else, we're bringing on the fear response in a gradual way so that children can learn that they can tolerate it and that nothing terrible happens to them as a result of thinking about the traumatic memory. So we know that the trauma narrative can help the child to organize the emotional and physiological effects of an experience and help them learn the difference between thinking about the trauma versus actually experiencing it. We also want them to learn that they can revisit the memory, and although it will always be sad, they don't need to feel overwhelmed. And ultimately, what we're looking for is habituation. We want their distress levels to habituate so that they can remember the trauma without intense disruptive fear or anxiety. So another way to think about this is to use this model. In the presence of a trauma reminder, for example, maybe I see somebody who looks like my abuser, or maybe the trauma reminder is my own memory of the abuse. I start to have these automatic thoughts of, it's happening again, I'm not safe, I can't handle these feelings. And in response, I feel terribly sad, I feel distressed, I want to avoid, I want to distract and numb. And when I do that, I never get to experience that actually nothing bad happens, and I never get to find out that I could handle it. But when I do avoid thinking about it or distract myself through risky behaviors or try to numb, I do have some lowered physiological arousal. So in a way, it's working. The treatment for PTSD actually deliberately focuses on the memories in a safe environment so that we actually experience some distress, but that distress ultimately comes back down through a process of habituation. And then we develop more adaptive thoughts. These memories can't hurt me, I'm safe, I can handle these feelings, and we may feel calmer. So a key thing for you to know is that avoidance maintains trauma-related symptoms. Not talking about the trauma does not help the child because they're already thinking about it. And in fact, PTSD is characterized by this sort of back and forth biphasic reliving partnered with denial and intrusive and numbing responses. So kids are going back and forth between these two different re-experiencing and then numbing. What we want to do is try to make them stay with the memory in a tolerable way, starting with a lower distress and moving on to higher distress memories, and learn that they can habituate to those emotions and that they can feel less physiological arousal over time. So the main steps involve developing the narrative. We begin by writing a narrative. Usually we start out with a non-traumatic chapter, like tell me about yourself, and then we start writing about the event slowly. For example, I would start with the part that's least distressing and then move on to a more distressing part. As a therapist, you're praising the child throughout the process, and it's not important that this be an accurate, detailed memory. In fact, it's not going to be a court document. It doesn't have to be accurate. It's what the child experienced. And it usually takes more than one session, although they recommend not more than 6 sessions be spent on the trauma narrative. We want to create feelings of safety throughout the process, letting them know that they're safe. One thing I often will say to kids is you have 1 foot in the past and 1 foot in the present, but you're here safe with me. Take ratings of distress throughout. We don't rate how scary it was when it was happening. We rate how scared they feel now talking about it. And it can be good to pair this with some relaxation before and after the trauma work. You want to be thorough. You want the child to either write about all memories of one event, or if there's multiple stressors, to write about the worst one. And you want them to describe their thoughts and feelings too, letting them have some reassurance throughout and use their coping strategies to get through it. Once you've written about the traumatic event, we usually write a final chapter about how they have changed, what they know now, and advice they would give to another child. This tends to be very positive for kids. And then throughout, the exposure part is that at every session, we have them write everything that they've written. So when they've only written 1 paragraph, they read that paragraph back. When they've written 5 paragraphs, they read from the start. And they keep reading them until they habituate and their ratings of fear decrease. Once the narrative is written and it's been read many times, you can go through the narrative and look for cognitive distortions, things like it's all my fault, it's going to happen again, if I had done something differently. You don't ever want to critique those thoughts during the writing of the narrative or even during the habituation phase, but once they've habituated to it, you can go back and use cognitive restructuring to address these thoughts and think about what I say to kids is there anything in this narrative that you feel differently about now, or you'd like to go back and tell yourself something different? And then we can insert those new, more helpful thoughts in the narrative. So this is just a quick example of what it might look like. Your first trauma narrative session, what the agenda for the session might be, your second through however many, 6 trauma narrative sessions, and then your last one. Many people have concerns that doing a trauma narrative will re-traumatize a child, but remember that the emphasis is on gradual retelling with habituation. So we're doing it in a way that's tolerable for them. And another thing that clinicians sometimes ask me is, isn't it expected that they be afraid of the traumatic events? Our goal is to help kids learn that the memory of the event cannot hurt them. We don't want them to habituate to the trauma itself. And in fact, you would never do this work with a child who is currently experiencing trauma exposure. In fact, if someone's experiencing current trauma exposure, your goals clinically are to get them safe, not to work on processing traumatic events. Certainly, I'm not sure I can handle hearing about this stuff is a concern I really resonate with. It's very important to seek support from your colleagues. And remember that this is a way in which you're helping the child. And always remember that you're not creating the memories are already there and the child is thinking about them all the time. A frequent metaphor that's used in this work is the idea of pulling out a splinter. The splinter is in the skin and it's causing pain and infection. To get it out is going to be painful, but it's necessary in order for healing to take place. So as we wrap up, I just wanted to show you a client that I worked with many years ago. This is a pseudonym. This is a kid who had witnessed domestic violence. I'm showing you here her child behavior checklist and youth self-report scores, as well as her PTSD index, which was initially very highly elevated by her report and her foster mother's report. I treated her for trauma. These were her top problems that she told me about in treatment. I feel sad when my brother feels sad. I feel sad when I think about not being with my mom. And then the foster mom, on her behalf, had these top problems. And here you can see her trauma narrative that she created. She wanted to create we actually put it in a manual that was information about domestic violence to help another kid. Here's one of her chapters where she wrote about what is domestic violence. Here's her narrative, continued, and then at the end she did a little about the author page. So at the end, the child has a product that they feel really good and proud of. Okay, so I will stop there, and I hope that you all have questions for me.
So we have some time now. Please chat in any questions or comments that you have for Dr. Bierman, and we'll share them with her. And I see a few that kind of came in from the beginning. So let's see. Oh, actually, this is a great one. I hope you might be able to address this, Sarah Kate. So one is Lynn says, I'm a case manager and work with a number of teens who have a PTSD diagnosis but who are not in treatment. Part of my job is to encourage them to get into treatment, but while they aren't, how can I help them in reference to trauma? I know that's not treatment necessarily, but I think it's a great example. What would you recommend?
Yeah, I mean, I think when a kid is not in treatment, we don't want to be doing any trauma exposure. We don't want to do any prolonged exposure because that really needs to happen in a very safe, intensive way. But it's always great to teach kids more emotion regulation coping skills. So things like teaching kids how to relax their body physiologically, like with deep breathing or progressive muscle relaxation or visualization. Those are just really good strategies for kids. Kids who've experienced trauma, and particularly those who have PTSD, tend to have responsive sympathetic nervous systems, so that can be really helpful. I also think that problem solving, if you remember when I showed kind of common elements of different treatments that focus on different disorders, problem solving kind of pops up across all of them because it's just a great coping skill to teach kids how to systematically, come up with the name of a problem, brainstorm multiple solutions, learn how to evaluate solutions in terms of their pros and cons or their costs and benefits, and then pick a solution and try it out. So I think both relaxation and problem solving are great kind of coping strategies to teach kids who are not in an intensive treatment but could benefit from emotional regulation.
Yeah. And one of the things I would add, and I don't know how you feel about this, Sarah Kate, but I also think as a case manager, sometimes even if they do have a diagnosis of PTSD, that doesn't necessarily mean somebody has sat down with them and explained to them what that means and what treatment can look like. So from my perspective, I think another thing that a case manager can do is provide some psychoeducation and a webinar like this that kind of lays out what treatment might look like and what some things might do that can help. Is also something that a case manager can do, is just provide psychoeducation. We can't assume that just because kids have PTSD, a diagnosis of PTSD, that somebody actually sat down with them and has done that work.
Yeah, I agree with you, and I would just add that even psychoeducation for kids who are, if they actually have PTSD, can be sort of triggering. So you would only want to do that in a very safe environment. One of the things that they've shown from some of the outcome data from trauma-focused CBT is that some kids actually get better during the psychoeducation phase, which is good and a good reason to do education about trauma, but it also means that probably they're feeling some anxiety when they talk about what is domestic violence or what is sexual assault. Even if they're not talking about their own experience, it can still be anxiety-provoking just to talk about those topics, which is not a reason to avoid it. It's just something to be aware of. Right.
So a bunch of questions coming in. Here's one. If a child, and I think you kind of addressed this, but it's a little bit more in depth. If a child you're working with has multiple complex traumas and one type has ended, but another type of trauma is currently occurring, and I think you kind of addressed this, but would you still not treat the child for the first type of trauma?
I would not.
For instance, yeah.
Yeah, when kids are currently in danger or experiencing trauma exposure, it's not recommended to do prolonged exposure. It's recommended to try to get them to be safe.
Okay. And so here's another one. Many of the patients I work with are being sent home from school for behaviors relating to conduct or oppositional defiant disorders. At times, they are not violent or threatening, but are more distracting others and refusing to do work. How can I assist the child, the parents, and the school staff to keep the children in school?
Yeah, great question. So really, I would so encourage you to find yourself, if you don't already have, a good behavioral parent training intervention, many of which have classroom companion interventions. So for example, Defiant Children has a classroom companion for teachers, and others do as well, and be working directly with the parent and the teachers, not with the child. So what we know about disruptive behavior disorders is that work with individual children, focusing on them directly, doesn't seem to help much. It seems like it should, but it just doesn't. But working with parents and teachers to change the contingencies in the child's environment is super effective. So I would really say to them, I want to help make your lives easier, teacher and parents, by teaching you some strategies that you can use with this kid. And, you know, we could meet 10 or 15 times, and it could help you with this kid, and it could help you with future kids, especially for teachers.
You know, and I don't mean to sound like a broken record, but Sarah Kate, I think, again, that psychoeducation piece, I think, owing to what you presented here today, is that if there's a known history of trauma with those kids with conduct or oppositional problems, I think sometimes providing some psychoeducation about that can be helpful to teachers and adults, and helping them make that connection that what they might be seeing as a manifestation of a history of trauma.
Yeah, absolutely. That this kid is not trying out to get them. This kid doesn't have better ideas of how to respond because of their past history.
Right, right. So, and then one last one we can try to squeeze in. With the ACE research, what do you know, and actually this one, what was the percentage of those kids in the ACEs who were special needs students, Spanish-speaking students, and girls when comparing them to counterparts? That's kind of a tough one. I'm not sure if I know that depth of the research.
Okay, I don't know that from the ACEs study, but I can tell you that kids with disabilities are at higher risk for experiencing traumatic events than their non-disabled peers. So whoever asked this question is very astute in knowing that that does place kids at risk. And of course, being girls increases the risk as well. So those are definite risk factors that can make abuse more likely.
Well, we are at time. I don't want to keep folks any further, but thank you for those great questions. And I want to thank Dr. Bierman for a wonderful presentation and a good view at some of these really important evidence-based approaches to helping kids with trauma. I want to sort of encourage you again to please, in the surveys that follow that you'll get right afterwards, please let us know if there's any additional topics that you'd like to hear about or get information about in this series on trauma-sensitive schools. And in addition to that, if we could just advance the slides for anyone who needs information, we have the information, I think, here at the end on how to get CEs for the presentation. Again, I want to thank you all for joining us, and I want to thank Dr. Bierman. Have a phenomenal day and be safe.
Thanks, everyone.